Hello, it's Dmitry again. Today I'll be covering another video from Mehlman Medical, the pulmonary section for the internal medicine PDF. Now, bear in mind that this is going to be, I think, something like 33-ish pages, more like 37 to 38 pages long. So I might cut this up into two different videos potentially. But let's just get right into it. So volume. This is what it says, annoying long volume terminology. So here's this general title volume. I don't like that the PDF's image is not very high quality, but whatever. Title volume, you can see there VT, or it says TV. Yeah, TV or VT. So showing that little area between 30 and 37. When you go much above that, you can see the inspiratory reserve volume. When you combine the title volume and the inspiratory reserve volume, that gives you the inspiratory capacity. We also have this thing that dips a little bit below the title volume. That's called the expiratory reserve volume. And when you combine the expiratory volume and the title volume and the inspiratory volume, which is the total range, we call that the vital capacity. Now, below the expiratory volume, that lower dip, below that is called the residual volume. That's the amount of air that you cannot get out of your body no matter what. And so when residual volume is combined with the expiratory volume, you call that the functional residual capacity. That is to say how much volume is in your lungs after a normal breath is out. Now, all the variation from the most inhaled to the amount of air, the amount of basically volume in your lungs after you inhaled the most, including all the air that you can never get out, that total amount is called the total lung capacity. So that's just a little bit of a definition game right there. So FEV1, which is the forced expiratory volume in 1 second, the amount of air one can forcibly exhale in 1 second following a maximal inspiration. FVC, or VC, forced vital capacity, the total amount volume of air one can maximally exhale following maximal inspiration. FEV1, or FVC, slash FVC, over FVC, which is the ratio used to differentiate between obstructive and restrictive lung diseases. Basically, when you have obstructive lung disease, the air doesn't want to get out, while restrictive lung disease, the air doesn't want to get in. And so if you have a very, let's say you have let's say an obstructive lung disease, you can breathe in and you can have a lot of like functional forced vital capacity is high, but the FEV1, which is the forced expiratory volume in 1 second, is low because it takes a lot more time because it's obstructive to get air out of your system. So you will have a low FEV1 slash FEVC ratio in the case of an obstructive disease because it's hard to get air out of your lungs. Conversely, for restrictive lung disease, it'll either be normal or be elevated because the FEV1 is not impacted meaningfully, or it could be slightly lower, while the FVC is significantly limited because of the restrictive disease. Total lung capacity, the TLC, total lung capacity, the total amount of air in the lungs following maximal inspiration. TV, or V with a little t at the bottom area, it's called tidal volume, the amount of air inhaled plus exhaled during normal / casual breathing. IC is the inspiratory capacity, the maximum amount of air that can be inhaled after a normal casual exhalation. IRV is the inspiratory reserve volume, the additional amount of air that gets inhaled that can be inhaled after a normal inhalation. ERV is the expiratory reserve volume, additional amount of air that can be exhaled after a normal exhalation. FRC is the functional residual capacity, the volume of air remaining in the lungs after a normal exhalation, while an RV is called the residual volume, the volume of air remaining in the lungs after a maximal exhalation. So that's the amount of air that you can never really get out of your lungs. And that's what complicates trying to figure out lung capacity because some of the air never leaves the lungs, so. DLCO, not a lung volume term, but you'll handle it. Diffusion capacity of the lungs for carbon monoxide, reflects extent to which the gas exchange is occurring across the pulmonary capillaries. For USMLE purposes, it is decreased in every pathologic lung condition, but increased in asthma. This is thought to be due to the combination of transient increase in blood flow through the pulmonary capillaries plus the additional hyperinflation during the acute episodes. In other words, if you get a big paragraph question where you're not sure what's going on, but they say the DLCO is reduced, you can say, cool, not asthma. Or if they say the DLCO is high, you could just select asthma without even reading the question, basically. Good to know. Obstructive versus restrictive lung disease. So we have obstructive pattern where we have a very large overall total lung capacity with a lot of residual volume, as you can see, which is the amount of air that you can't really get out. Well, conversely, compared to restrictive type, there's a limited amount of residual volume compared to normal, but not by a huge difference, but the overall total lung capacity is significantly reduced. And so, even if the tidal volume across all three is relatively similar to each other, the restrictive pattern has a lot smaller total lung capacity, while the obstructive pattern has a larger total lung capacity, but a lot of that's residual volume that you can't get out of your lungs. Make sense? Let me put this back up here. Obstructive lung disease, high yield conditions. Okay, so obstructive lung diseases include asthma, COPD, chronic bronchitis plus emphysema, and old age. That is to say, a healthy person aged 70 versus 20. Yeah. So it just becomes more obstructive-like over time. So FEV1 is decreased, FEC is decreased. The FEV1 over FEC is decreased because it's less than 70%. Normal is 70%. Yeah, because the FEV1 is reduced a lot more than the FEC is comparatively. The TLC increases, FEC varies or is lower. The tidal volume is going to be variable, or stay about the same. It says, I guess. The IC will be variable or lower. IRV, inspiratory reserve volume, will be around the same or lower. The expiratory reserve volume is going to be lower. The FRC, which is a function of residual capacity, increased due to the air trapping. Reserve volume is going to be increased due to air trapping. Yeah, the DLCO is going to be decreased, but in asthma, increase on USMLE. That's the exception to the rule. What about restrictive types? Pulmonary fibrosis due to any cause, i.e. idiopathic radiation drugs, autoimmune disease, and also pneumoconiosis. So if FEV1 will be either around the same or will be lower, functional vital capacity. Am I saying that right? Forced vital capacity. Forced vital capacity will be lower, and that's why will be an increase in the FEV1 to FEC ratio, because the FEV1 is not meaningfully changed. Well, it might be slightly lower, but the FVC is significantly lower, and so the ratio is different. It's greater than 70 to 80%. The total lung capacity is lower, though. FEC is lower. Tidal volume is lower. The inspiratory capacity is lower. The inspiratory reserve volume, the expiratory reserve volume, those are lower. The functional residual capacity is lower due to a decrease in lung compliance, and the residual volume is lower due to a decrease in lung compliance. The DLCO is lower, or it's the same if neuromuscular. The reason why FEV1 FEC is an increase or the same in restrictive as compared to a decrease in obstructive is because of the radial traction, which is a stickiness on the outside of the airways, such as from fibrosis, that prevent them from closing as rapidly as an obstructive. If you feel iffy on lung volumes, a general point to remember is that they're basically all decreased in restrictive due to the decrease in compliance, but various ones are increased in obstructive because the air cannot get out. Lifetime inhalation of particulates, i.e. non-smokers simply living in a city, cause an accreted effect on the lungs akin to a very slow onset of COPD. So, if the USMLE asks for lung volumes in a healthy 70-year-old versus a 20-year-old, select arrows for the former consistent with the obstructive lung disease. Flow, volume, loop, garbage. Okay. I don't mind flow volume all that much. Sometimes it's a little bit confusing, admittedly. So that's normal. That's the restrictive, and that's the obstructive in the purple there. Now you can see how there's a shift to the right. There's a lot smaller area of you're working with when it comes to the restrictive, and the obstructive is a lot further to the left. However, the total area that they're working with is smaller compared to normal. Both of them are smaller compared to normal, which means there's less variation. So with normal, you have a lot more ability to meaningfully expel or inhale air effectively. With restrictive, obviously that's not the case. And with obstructive, it can do that theoretically, but it has a lot more limitations, you could say. Just because it's shifted left doesn't mean that it actually has more doesn't mean it has more volume to work with. It has more volume in principle, but not able to work with necessarily. That's why there's some limitations, you could say. Don't freak out about the above flow loops. For USMLE, I'd say, because remember, it's basically has a lot of residual volume, so you can't get that out necessarily. Anyway, let me go back to the note. Don't freak out about above flow loops. For USMLE, I'd say that most important point is that the expiratory component of the obstructive curve, purple, has a scooped out concave shape. This is because of the obstructive causes the flow rate to significantly be reduced throughout the expiration. What USMLE will do is give you a real bootleg Windows 95 type spirometry curve as per above in a 34-year-old note with no family history plus 5-year smoking history. You look at the curve and say, no idea what I'm looking at, but top of the curve is scooped out / concave, and I know that means obstructive, so I'm guessing between COPD and asthma here, which are both obstructive. I'll choose asthma is more likely over COPD in a young patient. Well, that's some good advice. Obstructive versus restrictive. Let's continue. So obstructive for shape, scooped out, concave appearance, expiratory flow rate. Airway obstruction causes big reduction in flow rate, which is why it drops precipitously and results in scooped curve. Inspiratory flow rate, less affected compared to the expiratory curve, can be normal or reduced. Volume, wider curve due to increased total lung capacity from air trapping. What about the restrictive type? Smaller and more, the shape would be smaller and more symmetric, which you can see back. I want to go show you back that here, where it's more symmetric. Peak expiratory volume flow rate is relatively preserved, but overall size of the loop is reduced due to less volume in the lungs or maximal inspiration. Inspiratory flow rate significantly reduced due to diminished pulmonary compliance. Volume, narrower curve due to the diminished TLC from reduced compliance. Okay, what about shunt versus dead space? When we discuss VQ mismatch, V equals ventilation and Q equals perfusion. Good to know, because now Q means both perfusion and question. So decrease in VQ means a ventilation perfusion equals reduced ventilation relative to the perfusion, because again, the perfusion is higher and the ventilation is lower, or one or the other is the case. VQ is high, that means there's a reduced perfusion relative to the ventilation. A shunt leads, okay, this is important. A shunt leads to a decreased VQ, that is to say, refers to almost all lung conditions on USMLE. So decreased VQ means you have a reduced ventilation relative to perfusion. This also is caused by a shunt. So shunts cause a reduced ventilation relative to perfusion. Okay? Dead space is the opposite. Dead space increases VQ, which means that it refers to the joint just pulmonary emboli on USMLE. So dead space increases VQ, which means that it reduces the perfusion relative to the ventilation. So when you hear dead space, think reduced perfusion relative to ventilation, think elevated VQ. For shunt, think reduced ventilation relative to perfusion, reduced ventilation. Think about, it refers to almost all lung conditions in USMLE, and it's a low VQ. But dead space is very specific for pulmonary emboli. So when you have a PE causes an increased VQ, causes an elevated VQ mismatch, causes dead space to exist, and it increases or reduces the perfusion relative to ventilation, which makes sense, right? So pulmonary embolism reduces perfusion, which causes you to have a high VQ, which means you have dead space, okay? And so conversely, everything else causes a reduced ventilation, which means that you're going to have a low VQ, which means you're going to have a shunt. If you hear the term shunt used in isolation, this refers interchangeably to pathologic shunt, where the decrease in VQ occurs to the point that the patient's arterial oxygen becomes decompensated. In other words, the reason why a patient has a decreased O2 sats is because there are some sort of lung problem where the aeration of the alveoli is decreased, but there's nothing wrong with perfusion. That is to say, blood flow isn't cut off to the lungs. Sorry. Decrease in VQ can also refer to the physiologic, i.e. normal shunt, as we see as along bases, where the VQ is 0.6. This is despite both ventilation and perfusion increasing in the apex, going to the base. Gravity pulls blood down more greatly than the air, so perfusion increases towards the base, whereas ventilation only increases somewhat. So basically the point is that even though both perfusion and ventilation are better in the base of the lungs and the top of the lungs, because both the blood is pulling down there and the oxygen is pulling down there, the blood pulls a lot better there, so the perfusion is much better, so you only have a 0.6 down there. Again, normal would be 1. 1 is supposed to be considered the ideal situation. It's about, equal. But it's about 0.6 in the bottom of the lungs because the perfusion is much better there compared to the ventilation. And the top of the lungs, I think it's like a 2 or something like that. It's like a 2 or a 3. I want to say 3, but that sounds a little bit high. Let me check actually right now. VQ of top of lungs. 3.3. I was afraid of saying 3 because I'm like, that must be too high, right? No, it's actually 3.3. So my intuition is correct. My reservation and restriction in my answers was a little bit too much. Yeah, it's actually 3.3 to 3, something like that. The top of the lungs. And why is it that case? Doesn't it have worse perfusion? Yes, it has worse, doesn't it have worse ventilation? Yeah, it has worse ventilation, but the perfusion is so bad, comparatively speaking, that the ventilation outpaces it. So it's all relative, if you think about it. Where were we? Yeah, so VQ is decreased at the base is shunt. Areas of the lung with decreased VQ attempt to compensate via hypoxic vasoconstriction, where the blood vessels constrict in order to redirect, that is to say shunt, blood to better ventilated areas. In other words, if an area has low ventilation, constriction of blood vessels in that area lowers the perfusion in order to increase the VQ ratio and prevent wasting of blood flow. So yeah, that's an important mechanism. The body says we want to make sure that we have our blood distributed to the areas that have the most oxygen, and vice versa. If it's not getting much oxygen, we need to divert the blood somewhere else. If you hear the term dead space used in isolation, this refers interchangeably to the pathologic dead space, where the increase in VQ occurs to the point that the patient's arterial oxygen becomes decompensated. In other words, the reason why a patient has a decreased O2 saturation is because the blood flow is cut off to the lungs. This will be PE and air, fat, amniotic emboli on USMLE because of the clot and embolizes to the pulmonary arteries, compromises blood flow to the pulmonary tissue. The elevated VQ can also refer to dead space processes that are non-pathologic. Alveolar dead space equals natural physiologic increase in VQ within the alveoli, where some areas have received more ventilation than perfusion, that is to say, the apices VQ of 3.0 compared to the bases of 0.6. This is because the gravity pulls blood down more than air, so as the apices of the lungs, there's relatively less blood flow in comparison to how much those areas are ventilated. Anatomic dead space refers to the parts of the respiratory tree that are naturally ventilated but do not partake in a gas exchange, such as the trachea, bronchi, and terminal bronchioles. There are areas that do not receive perfusion when gas exchange occurs for respiratory purposes, despite being ventilated by air moving in and out. Physiologic dead space is the sum of anatomic and alveolar dead space. So, the way he defines it, and I'm sure a lot of people who do define it, they're defining physiologic as being both the alveolar and the anatomic. So I have heard before that they almost conflate the alveolar with physiologic, and they can say anatomic is different. Anatomic is its own thing, where it's like it's normal for it not to have any real gas exchange, like the trachea. But in this case, they're saying that the alveolar is the normal area that there is gas exchange. And when you combine that, when you have the pathological alveolar dead space and you combine it with the anatomic dead space, that is called the physiologic dead space. Oh, no, sorry, I'm mistaken. They're saying alveolar is the natural physiologic. Okay, so they're saying that alveolar dead space that's still natural is physiological, which is true. So still, I guess physiologic in this case, physiologic refers to still the non-pathological dead space. So physiology and pathology are related but different concepts. And so there's an alveolar dead space, I guess, in addition to the anatomic dead space of the trachea and so forth. And so just be aware that when you say physiologic dead space, we mean both the anatomic and, again, the alveolar dead space, which is the natural physiologic form of the alveoli where they have limited perfusion. To understand shunt versus dead space, both involve a right-to-left mixing of deoxygenated blood right with oxygenated blood left. The shunt is a right-to-left mixing where the right is created by areas of alveoli not receiving enough oxygen. Dead space is right-to-left mixing where the right is due to the decreased perfusion to areas of the lung. An area of the lung underventilated or perfused could be said to represent a zero in terms of the oxygenation it contributes to the blood. That zero is mixed in with all of the other areas of normal lung. This means that the average of all the areas of the lung cannot achieve normal oxygenation because that is zero is mixed in. This is why arterial O2 will be decreased when we have pathologic shunt or dead space. In both pathologic shunts, that is to say COPD, pneumonia, asthma, and dead space, PE, there are still areas of lung that have normal VQ. Administering oxygen to these patients will have differing effect, where the shunt is less effectively remedied, often due to the extent of the hypoxic vasoconstriction, which causes a high fraction of blood to bypass normal VQ areas altogether, even though a small fraction is diverted appropriately to them. The net result in oxygen administration still fails to increase the PaO2 in the shunt. In dead space, where the hypoxic vasoconstriction doesn't occur because the ventilation is normal, administered oxygen to normal VQ areas helps because it comes into contact with more blood overall. This can essentially be simplified as dead space by definition is a primary decrease in perfusion. Shunt causes a secondary decrease in perfusion, but we don't call the secondary decrease in perfusion dead space. Hypoxic vasoconstriction due to shunt is a mere compensatory response to the decrease in ventilation, but it happens to be the case that the blood that is shunted away from the lungs can be greater in volume than the primary decrease in the perfusion in the setting of a pathologic dead space. Alveolar arterial AA gradient stuff. A is the alveolar oxygen, and the little a is the arterial oxygen. So big A for alveolar, little a for arterial. In settings where the patient's arterial oxygen is low, the AA gradient, which is again the alveolar arterial gradient, normally 510 mmHg, tells us that where there is an actual lung pathology, or if the patient is merely hypoventilating. In other words, the AA gradient, the lungs are messed up. The patient is breathing normally, but there is a problem such as impediment of a gas exchange, poor lung compliance, or pathologic shunt or dead space. The patient has low arterial oxygen despite sufficient respirations, where alveolar PO2 is normal in unaffected areas of the lung. The normal A in unaffected areas of the lung minus the low A in the blood makes the alveolar arterial gradient high. Normal AA gradient equals the lungs are normal. Patient has just not breathing enough, that is to say, quality and or quantity of respirations is insufficient. This refers to opioids, heroin, benzos, and barbiturates. Because these agents cause respiratory depression, normal AA gradient is also sometimes seen in patients on ventilators. The patient has a low arterial oxygen merely because of insufficient respirations, where the alveolar oxygen is low throughout the lungs. The low A, alveolar, throughout the lungs is due to the poor respirations minus the low A, arterial, in the blood, making the AA not elevated. The NBME doesn't expect you to know the exact numbers for the AA gradient. The Q, which is the perfusion, might give you, or the question. The question might give you the answer choices where the AA gradient is either 40 or 10, where you have to say, well, clearly the answers with 40 are high and the ones with 10 are normal. So the question is a patient who's had opioid toxicity and low O2 stats, you would select a choice with 10 for an AA rather than one with 40. Not dramatic. USMLE also wants you to know that the mechanism of the patient's hypoxemia and pulmonary edema is high AA gradient. This makes sense as a transudate in the alveolar spaces impedes gas exchange, but the patient's respirations are otherwise fine. Old age in a healthy person causes an increase in the AA gradient, a decrease in the arterial PO2, an increase in the total lung capacity. This combination is answered on the NBME, that is to say, even if people are non-smokers, as we live our life inhaling particulates from car exhaust, etc., the lungs experience obstructive changes with age, essentially very slow COPD. Choose normal AA gradient in patients on ventilators who have PCO2. The latter tells us the arterial PO2 is low because of insufficient respirations. My biggest advice is not to automatically assume high AA gradient for every scenario of low O2 stats. The mistake I see students make is they think just think any issue with causing low O2 stats saturation means an AA gradient must be high, which is not the case necessarily. High yield pulmonary respiratory tract cancers for the internal medicine. So this is kind of a detour. Well, not exactly. It's a slightly different section. So we're talking about small cell bronchogenic carcinoma. Small basophilic purple cells, NBME can describe these cancers as twice the size of lymphocytes. Occurs centrally in the lung, that is to say hilar or medially. Smoking is the biggest factor. Paraneoplastic syndromes exceedingly high yield. SIADH, ADH secretion. 2. Cushing syndrome due to ACTH secretions. 3. Lambert-Eaton syndrome production of antibodies against presynaptic voltage-gated calcium channels. 4. Cerebellar dysfunction, ataxia, anti-HU-YO antibodies. Treatment on 2CK is chemotherapy. Do not do surgery. I believe this is the only time I've straight up seen chemotherapy as the correct answer on NBME. It's for the small cell bronchogenic carcinoma. Okay, so, and also, by the way, the small cell bronchogenic carcinoma stains positive for keratin may have keratin pearls on histo pink circles. Oh, this might be this one right here. Why do they label like this? What's going on? Okay, this is a different thing. Sorry, squamous cell carcinoma, squamous cell now. Stains positive for keratin may have keratin pearls on histo pink circles. So that is in fact squamous cell carcinoma. Similar to small cell, occurs centrally in the lung, i.e. hilar medially, smoking biggest risk factor. In other words, the two cancers that start with an SSS sound for central, that is to say small cell squamous cell, are central, can cavitate if USMLE gives you small lung cancer with a cavitation, that is to say cavity is whole, that are this answer is going to be squamous cell. Highest yield point is that it secretes the PTH related, which is parathyroid hormone related peptide, which resembles PTH in terms of its function. And this acts like a PTH and increases calcium and decreases phosphate. But this is also not the same as PTH. Endogenous PTH is suppressed due to the negative feedback system from high calcium. In other words, choose a down arrow for PTH in squamous cell carcinoma of the lung. So it's a little bit of a tricky one because it's increasing PTH related peptide, but not PTH itself. And so it actually suppresses the endogenous PTH. Yeah, squamous cell carcinoma. So remember, when you think about, small cell bronchogenic carcinoma, think about Lambert-Eaton syndrome and think about ACTH secretion with Cushing syndrome and SIADH, that kind of stuff. But for squamous cell carcinoma, what you should be thinking about is the PTHRP. What about the adenocarcinoma of the lung? Adenocarcinoma means the cancer of glands. If the question says something about biopsy showing glandular morphology, you know they're talking about the adenocarcinoma. The answer on the USMLE for lung cancer is a non-smoker, classically female non-smokers, but I've seen NBME questions with this in men. Normal ground/earth radiation due to the radon is accepted cause of lung cancer in non-smokers. There's NBME question where they mention non-smokers living in a basement and develops lung cancer. The correlation is probably nonsense in real life, but it's an NBME question somewhere. It does not occur centrally on NBME exam, unlike small cell and squamous, and hence will be described as an apical or peripheral lung lesion in non-smokers. Apical tumors can be known as Pancoast tumors and cause Horner syndrome like meiosis, ptosis, and anhidrosis due to the impingement on the C8 superior cervical ganglia, sympathetic nerves. They can also cause a superior vena cava syndrome, flushing of the face plus congestion of the neck and veins, or bronchocephalic or brachiocephalic syndrome, only right side of face or neck due to the impingement on venous return. Plus, Pemberton sign is worsening of flushing plus neck vein congestion when raising the arms above the head. Can be associated with migratory thrombophlebitis like Trousseau sign or malignancy. The latter is not limited to the head or head of pancreas cancer. Adenocarcinomas in general are known to be associated with hypercoagulable state due to the malignancy. USMLE won't ask specific mechanism, but liberation of tissue factor 3. By these cancers is proposed etiology. Associated with hypertrophic osteoarthropathy, clubbing plus hand pain due to the lung cancer, mechanism is fibrovascular proliferation. Literature says adenocarcinoma of the lung is most common cause, although the association is not 100% specific. Large cell carcinoma. Large cell carcinoma is a non-existent lung cancer on USMLE. Bogus garbage diagnosis. I don't think I've ever seen this assessed. Okay. I'm going to take a brief break. Okay, we're back. Bronchogenic carcinoid tumor. Pulmonary nodule that secretes serotonin or serotonin-like derivatives, resulting in a carcinoid syndrome, that is to say, tachycardia, flushing, diarrhea. A type of neuroendocrine tumor, carcinoid tumors are classically appendiceal and of the small bowel, but you should be aware that the bronchogenic carcinoids exist. USMLE wants urinary 5-hydroxyindyl acetic acid 5-HIAA for initial step in diagnosis. What about mesothelioma? Cancer of the mesothelial cells, answer on MBME, seen in patients with prior occupational exposure to asbestos. Asbestosis occurs first, which then gives rise to the mesothelioma years later. Shipyard and construction workers are buzzy for prior occupational exposure for mesothelioma. Asbestosis will be described as pleural or supradiaphragmatic plaques, soft tissue plaques seen on chest X-ray. Pulmonary biopsy shows ferruginous bodies. carotinin positive, a protein which is highly indicative of mesothelioma on staining. Mesothelioma appears as a whitish cancer and is described as an encasing in a pleural-based tumor, i.e. circumferentially surrounds/wraps around the lungs. Nasopharyngeal carcinoma can be caused by Epstein-Barr virus, a type of squamous cell cancer carcinoma of the airway. Laryngeal cancer, squamous cell carcinoma of the vocal cords. Smoking is a major risk factor. New NBME question wants you to know that this spreads to cervical lymph nodes. Laryngeal papillomatosis, pediatric condition characterized by warts of the vocal cords. Lesions will have a papillary structures on biopsy due to the HPV 6/11 exposure from the maternal vaginal canal. Pneumoconiosis for IM. So now we're going to pneumoconiosis. What do we have? So asbestosis, let's talk about it. Asbestosis, as already mentioned above in the mesothelioma section, this is associated with the shipyard workers, construction workers, and electricians. It can give rise to mesothelioma and later in life. The above ferruginous bodies is a dumbbell shape. Choose macrophage as the answer on USMLE for the cell that initiates pulmonary fibrosis in response to asbestos and in general. Causes restrictive lung pattern. So macrophages, okay? Beryliosis. Beryliosis, occupational exposure to beryllium in the aerospace aeronautical industry, can cause restrictive lung patterns, can cause granulomas. Silicosis. Occupational exposure to silicon, sand, in foundry or stone quarry workers, can cause egg shelf calcification in upper lobes, increases risk of tuberculosis infections. Avoid and anti-TNF alpha agents, that is to say infliximab, adalimumab, and entanercept in these patients due to the increased TB risk. TNF alpha needed to suppress/fight the tuberculosis. Anthracosis, aka coal miner's lung, black discoloration of the lung, I guess it'd be like black lung, I guess, can be either obstructive or restrictive. Kaplan syndrome, this is the bigger one, I guess. No, it's not. That's the next different section. Kaplan syndrome, rheumatoid arthritis plus any pneumoconiosis, presenting as a pulmonary nodules. Clinical relevance is that patients with the rheumatoid arthritis are at increased risk of developing pneumoconiosis if they have a workplace exposure. Let's continue. High yield general lung conditions for internal medicine. This is a big one right here. Oh, this is long. So the first one here, which is a long one. So high yield general lung conditions for IM. Idiopathic pulmonary fibrosis, usual interstitial pneumonitis. The answer on USMLE for a patient over the age of 50 who has a 6 to 12 plus months of unexplained dry cough, this is how it shows up 4 to 5 times. 4 out of 5 times. Textbook restrictive lung disease with a variable equal or increased FEV1, FVC. The reason for the FEV1 or FVC being greater than an obstructive lung disease is radial traction, as mentioned earlier. Chest X-ray and CT scan show reticular or retroreticulonodular pattern. These descriptors are exceedingly high yield on USMLE, where students will overlook them in the vignette, but they are hugely buzzy for restrictive lung disease. They are colloquially known as honeycombing, but I have not seen the USMLE give a care about the latter colloquialism. They frequently just say reticular and reticulonodular, and then you know right away, boom, restrictive lung disease, i.e. fibrosis, etc. So again, it says here, they frequently just say reticular and reticulonodular, and then you know right away, boom, restrictive lung disease, i.e. fibrosis, etc. Tangentially, it's not my observation that NBME will say reticular granular frequently for NRDS, but the two vignettes are clearly disparate anyway. So here's a picture here. You can see this picture. It says fibrosis, and then it says shaggy heart borders. Okay. It says after chest X-ray and spirometry are performed, 2CK wants high-resolution CT of chest as the answer for the next best step. Honeycombing equals reticular/reticular nodular pattern. The new 2CK NBME wants lung biopsy as the answer to confirm the diagnosis of interstitial lung disease, that is to say, idiopathic pulmonary fibrosis after imaging. The vignette can also mention the allowed P2 means pulmonary hypertension with dry inspiratory crackles heard bilaterally. 1 out of 10 times the question will be patient over 50 with increasing fatigue and shortness of breath over 6 to 12 months with 1 month of cough where it initially sounds like heart failure, and they'll say chest X-ray shows interstitial markings instead of the reticular nodular patterning. However, they say the patient has a elevated FEV1 FVC ratio showing restrictive pattern in the stem, which gives it away. You need to know that the usual interstitial pneumonitis is another name for idiopathic pulmonary fibrosis. Yes, the name is weird, but it's not my opinion, and it's asked twice on the NBMEs, where instead of writing idiopathic pulmonary fibrosis as the answer, they write usual interstitial pneumonitis. So that means that the usual interstitial pneumonitis is technically a broad term that can refer to many restrictive lung conditions, but as I said, on NBME, they use this synonymously with idiopathic pulmonary fibrosis. Treatment on 2CK for this would be pirfenidone, which is an antifibrotic agent that inhibits the TGF-beta-mediated synthesis of collagen. Next condition, we have COPD, chronic obstructive pulmonary disease, COPD. COPD equals a chronic bronchitis plus emphysema. Smokers will have combination of the two. When we say smoker has COPD, we are saying that he or she has chronic bronchitis plus emphysema at the same time. The term COPD can, in theory, apply to any obstructive disease of the lungs that is chronic, like asthma, cardiogenic, etc., but when the term is used without any specific condition attached, it refers to the combination of chronic bronchitis and emphysema. Hyperinflated lungs in COPD due to air trapping can push the heart to the midline. MBME will say there's a long, narrow cardiac silhouette or a point of maximal impulse palpated in the subxiphoid space. In left ventricular hypertrophy, in contrast, there will be a lateralized apex beat, or a point of maximal impulse in the anterior axillary line. Home oxygen is indicated on 2CK if the O2 sats are less than 88% saturation or 55 mmHg, or less than 89% saturation at 60 mmHg if the patient has a cor pulmonale. First-line treatment is now considered to be a long-acting muscarinic receptor antagonist, that is to say, for example, LAMA, with one L, such as tiotropium, or long-acting beta-2 agonists like LABA, such as olodaterol, either alone or in combination. If insufficient, add an inhaled corticosteroid like fluticasone. Should be noted that a question on the earlier NBME has ipratropium, SAMA, SAMA, as the answer for the first line in COPD, but there aren't any other antimuscarinic or beta-2 agonists listed. So the point is that if you are forced to choose a SAMA or SABA, that is to say albuterol, for example, on USMLE, these are okay, but newer guidelines say start with an LMAA or LABA. So stick with those two, which are going to be like olodaterol or tiotropium or something like that, preferably over albuterol. Exacerbation of COPD as a diagnosis in USMLE will always give a patient with high CO2. This is really important. In other words, if they give you a big paragraph and you're not sure about the diagnosis, if you see CO2 is not elevated, then the answer is not COPD exacerbation. which would have a CO2 elevation. COPD exacerbation can be triggered by minor chest infection, so always give antibiotics on 2CK, even though the etiology is usually viral. Patients with COPD are chronic CO2 retainers, so they will have a chronic respiratory acidosis, that is to say, an elevated CO2 and an elevated bicarb. pH can either be a decreased or compensated back into normal range. For 2CK, lung cancer screening with an annual low-dose chest CT is done in patients who meet all the following criteria. 1. Age 50 to 80. 2. Have a 20-pack year history smoking. And 3. Smoked within the past 15 years. Chronic bronchitis. Chronic bronchitis equals productive cough for the last 3 months in a year for 2+ years. Wright index is greater than 0.5 ratio of the thickness of the bronchial mucus secreting glands to the bronchial wall itself. Less than 0.4 is considered normal. Chronic bronchitis is known as a blue bloater because the mucus sits in the alveolar spaces and impairs gas exchange. This results in a ton, I'll use that term, a ton of hypoxic vasoconstriction, leading to a patient can become acutely blue and hypoxic during exacerbations. The hypoxic vasoconstriction of pulmonary vessels causes pulmonary hypertension. That is to say, if the vessels constrict, then pressure in the more proximal pulmonary arterioles increases. This is increased afterload on the right heart and can lead to right ventricular hypertrophy and right heart decompensation. When right heart failure, i.e. evidence of JVD or peripheral edema, occurs due to the pulmonary cause, we now call that cor pulmonale, as discussed in the cardio PDF. The pulmonary hypertension can cause a loud P2 and tricuspid regurgitation prior to cor pulmonale occurring. Do not confuse chronic bronchitis with acute bronchitis, which can present as a worsening cough in patients with or without COPD following a viral infection. This is a temporary irritation or inflammation of the airways that is self-resolving. So don't confuse the two. What about emphysema? Emphysema is the loss or destruction of alveolar surface area. When alveolar surface area is reduced, so is alveolar capillary surface. When alveolar surface area is reduced, so is the alveolar capillary surface area. Since the capillaries are within the alveolar walls, there's a decrease in gas exchange. Known as a pink puffer, since although gas exchange is impaired, sudden and acute increases in hypoxic vasoconstriction, as with chronic bronchitis, are not a feature. Bolus changes on chest x-ray are synonymous with the emphysema on USMLE. Smokers can get a centroacinar emphysema, proximal alveolar structure is destroyed. Alpha-1 antitrypsin deficiency patients can get a pan-acinar emphysema, entire alveolus is destroyed. What about an alpha-1 antitrypsin deficiency? Codominant genetic condition resulting in the emphysema and hepatic cirrhosis. ZZ allele in combo is worse and results in the disease, asked on USMLE. Alpha-1 antitrypsin is an enzyme produced by the liver that travels to the lung and breaks down neutrophilic elastase. Elastase is an enzyme that normally causes damage to the alveoli. Homeostatically, elastase is required in small amounts for the normal pulmonary function and cell turnover, but in high amounts it destroys the alveoli, resulting in emphysema. Vignette will give young adult who is sibling or parent who's early onset emphysema or cirrhosis. The USMLE question can absolutely say the patient is a smoker or drinks alcohol. For instance, they might say that the patient is 34 and has been smoking for 5 years and has bolus changes on chest x-ray, or that the father died from alcoholic cirrhosis, and the student says, oh, that can't be alpha-1 antitrypsin deficiency, though, because they said smoking and alcohol. But the key point is that their condition has increased the risk for early onset emphysema and cirrhosis. Normally, COPD should take 20 plus years of smoking to develop, not 5. So bear that in mind. They might throw you off a little bit. Say, oh, well, how could it be because of this? Well, typically, do you see that with somebody with 5 years of history? Probably not necessarily. So just be aware of that. They might try to throw you off. What about asthma's a long one, isn't it going to be? Yep. Wow. Okay, cool. Well, whatever. Okay. Asthma. Bronchospasm that occurs either idiopathically, hereditarily, or in response to certain allergens or cold air. 1/3 of patients with asthma only present with a dry cough and no problems of breathing. This is called cough variant asthma. It will often present as a patient with a dry cough that's worse in the winter. It can also present as a part of atopy constellation, that is to say, dry cough in winter, seasonal allergies, rhinoconjunctivitis, urticaria in spring, and eczema in the summer. Aspirin-induced asthma mechanism high yield for USMLE, inhibition of COX by aspirin, shunting of the arachidonic acid down lipoxygenase pathway, leading to an increase in leukotrienes, leading to an increased bronchoconstriction. Samter triad equals aspirin allergy, asthma due to aspirin, nasal polyps, increased expiratory phase, and as a buzzy phrase that will be thrown in quite a few asthma vignettes. It is not specific for asthma and can refer to any obstructive pathology, but I just make the note of it here because you will see it quite a bit for asthma and say, what does that mean? In obstructive conditions, it takes us a lot longer to exhale. FEV1 is decreased significantly. Acutely, asthma causes a decrease in CO2, an elevation in pH, and backyard to be basically unchanged. This is an acute respiratory alkalosis. Even though the patient is having difficulty breathing, CO2 diffuses quickly, whereas O2 diffuses slowly. So insofar as the patient's respiratory rate is elevated, CO2 will be decreased. Bicarb is unchanged because it takes the kidney about a day to alter the excretion. In contrast, CO2 is elevated in COPD because there's large amounts of hypoxic vasoconstriction due to the excessive mucus or chronic bronchitis or the decrease in alveolar surface area. So CO2 can't get out, even with the faster breathing. In asthma, alveolar surface area is intact, and the degree of mucus production and hypoxic vasoconstriction is not nearly as bad as the chronic bronchitis. The combination of decreased CO2 and decreased O2 in asthma, an acute asthma attack, is known as a type 1 respiratory failure. Eventually, the patient will begin to fatigue and breathing rate will slow. This will be observed as CO2 and pH rebounding to normal levels despite O2 remaining low. This means that the patient is in transition to a type 2 respiratory failure, that's to say hypoventilation, where we have an elevated CO2 and a decrease in O2. USMLE wants intubation as the intervention. A 2CK question gives the vignette of asthma and then asks for the best initial step in the diagnosis, leading to an answer of spirometry. The expiratory component of the curve, as discussed earlier, will appear concave. Should be aware of methacholine challenge can also be done to diagnose. This is a muscarinic agonist that bronchoconstricts and can induce symptoms. Never give during an acute episode. This can be tried between episodes. If you are forced to choose diagnostic modality, go with spirometry. USMLE cares about both outpatient management of asthma as well as the acute attacks. For outpatient management, consider these. 1. First-line treatment is beta-blocker agonist or beta-2 agonist, albuterol. For acute attacks, if the question says that the patient has weekly episodes or asks for what could be used to decrease the future episode if the patient is already on albuterol, the answer is inhaled corticosteroid, ICS, that is to say, for example, fluticasone. If the combination of albuterol plus an ICS is sufficient, the next step is increasing the dose of the ICS. If that doesn't work, add an LABA, like cimeterol, is the next step. If this is insufficient, agents such as mast cell stabilizers, leukotriene blockers, etc. can be tried. If the patient has a history of aspirin allergy, the latter in particular can be most effective. So the latter can be effective. The last resort for the outpatient asthma is oral prednisone. It is the most effective at decreasing recurrence of episodes, but we want to avoid it at all possible because of the risk of Cushing syndrome and a decreased linear bone growth in peds, so like in children. So first line treatment is beta-2 antagonist albuterol. And the second line would be like inhaled corticosteroid ICS like fluticasone. So continuing with asthma. Or this is asthma still. Asthma. So continuing with asthma, acute management of severe asthma attack, that is to say not outpatient, is nebulized albuterol, oxygen, and IV methylprednisone. Inhaled corticosteroids have no role in acute asthma management. NBME for 2CK wants you to know that any asthma patient who requires hospital management for an acute episode must automatically be given ICS, for example, as to say fluticasone, on discharge. In other words, if the patient If the patient isn't currently on an ICS, it must be commenced at discharge. I'm explicit here because this particular NBME question does not mention albuterol anywhere in the stem, but inhaled fluticasone is the answer. Another 2CK NBME question gives a patient who is currently not receiving any asthma medications, but who gets 2+ episodes weekly. The answer should be inhaled fluticasone plus albuterol. Students think this is weird because they jump straight to the dual management, plus are even audacious enough to put the ICS before albuterol in the wording of the answer, but it's what they want. Any patient with 2+ episodes per week needs an ICS in addition to the albuterol and can be commenced right away on dual therapy. I'm going to take a brief break right here before doing bronchiectasis. Bronchiectasis. So, oh yeah, by the way, I'm back. Anyway, so bronchiectasis, dilation of the airways. Ectasia means dilation that occurs due to the loss of musculature of the airways. Transverse CT scan will show cystic dilation of the airways. As you can see the diagram right there, most common cause worldwide is TB, tuberculosis. Most common cause in Western countries is cystic fibrosis, CF. But on USMLE, it'd usually be a smoker. Asthma does not cause bronchiectasis. Presents almost always as cups and cups of foul-smelling sputum. Foul-smelling means anaerobe, such as Bacteroides. One question on the 2CK forms gives bronchiectasis as the answer in a child who has right middle lobe syndrome, where they say there is scant white sputum, not cups and cups, and a thin, linear opacity visualized on the right middle lobe. If you think it's weird, complain to NBME, not me. Clubbing tends to be seen in these patients. It's not mandatory, but it's, to my observation, USMLE likes it for bronchiectasis. I'm going to give a little bit of a brief one on this one right now. I actually like Discern Sense, how specific he is to USMLE, the step 1 exam, because it's like there's all sorts of really weird, super specific things they like personally, which might not be reflective of how these things are in terms of reality. The one issue I might say is that if you're taking step 2, but also Comlex 2, this is better for step 2 rather than Comlex 2, so keep that in mind as well. That what the peculiarities of step 2 for the 2CK might not be the same thing as the peculiarities of Comlex 2. Maybe some of them overlap, I don't know. I haven't taken them. But keep that in mind if you're studying for Comlex 2 rather than step 2, or you're studying for both perhaps. Anyways, back to atelectasis. Atelectasis, confusing word that refers to the lung collapse or collapse of alveoli. Highest yield point for USMLE is the fact that it is the most common cause of fever within 24 hours of post-surgery. If this isn't the first time you're reading this, that might sound weird, but this is pass level and extremely important for 2CK. Most common cause of fever within 24 hours of post-surgery, atelectasis. There is one 2CK question I've seen where they say a woman had a C-section 2 days ago and the answer was still atelectasis. So even though it's most common less than 24 hours, just be aware the one question exists where, oh my gosh, it's 2 days later. The mechanism is related to the combo of pain meds plus sedation, plus sedentation, where the breathing becomes slower and shallower in hospital bed, leading to mild collapsing of some alveoli. This is why breathing exercises can be important post-surgery. Will often present as a bibasilar shadows or opacities. In other words, patients have had surgery yesterday, plus now has a fever plus chest x-ray, shows mild opacity at the lung bases. Answers are equals atelectasis. NBME assesses the obstructive, aka resorptive atelectasis. This is when an area of the lung distal to the obstruction from, let's say, for example, a tumor, can cause alveoli to collapse. This then increases the chance for pneumonia distal to the obstruction. 2CK internal medicine form has a endobronchial obstruction as answer for distal area of lung collapse, that is to say, for example, atelectasis in patients with lung cancer. Vascular occlusion by tumor is wrong answer. Makes sense as the tumor obstructs the respiratory tree, not the blood vessel in this case, but I've seen students accidentally choose the latter. Obstructive sleep apnea, OSA, can be obstructive, that is to say, usually from obesity, or central, that is to say, from brain-related. What USMLE wants you to know is that these patients develop chronic respiratory acidosis, that is to say, elevated CO2, elevated bicarb, pH is normal or low. Cor pulmonale can occur as a result of pulmonary hypertension from the hypoxic vasoconstriction. JVD, or peripheral edema, will be seen with cor pulmonale. Descriptors such as right bundle branch block, right axis deviation on EKG, and wide splitting of S2 all mean right ventricular hypertrophy. If the patient merely has pulmonary hypertension but not yet cor pulmonale, the vignette can say loud P2 or tricuspid regurgitation, hollow systolic murmur that increases with inspiration. Chronic fatigue and poor oxygenation can lead to dyspnea and depression. The answer on NBME is mood disorder due to a medical condition. Polysomnography, sleep study, is what USMLE wants to diagnose. Anaphylaxis. Acute dyspnea and bilateral wheezes in patients who are gardening, stung by a bee, who ate a particular food like peanuts, or who has commenced a recent drug, that is to say, for example, Bactrim, trimethoprim sulfamethoxazole, which is why it's called TMP-SMX. Vignette often gives tachycardia and low BP. Mechanism is IgE cross-linking on surface of mast cells and basophils that leads to degranulation and histamine plus prostaglandin release. Eosinophils can be recruited in response. USMLE wants a decrease in vascular resistance and elevation in cardiac output, or a decrease / no difference between the PCWP, which is a capillary wedge pressure. The treatment for this would be intramuscular epinephrine. The strongest beta-2 agonistic effect opens the airways. The strongest alpha-1 agonistic effect constricts the arterioles and restores the blood pressure. For anaphylaxis, NBME for 2CK asks, in addition to self-injectable epinephrine therapy, what is most appropriate therapy to decrease the recurrences is the answer venom immunotherapy, which desensitizes the patient to the antigen by allowing him or her to develop neutralizing IgG antibodies against it. What about scombroid? Scombroid misdiagnosed as seafood allergy. Bacteria in decaying meaty fish, for example, mahi-mahi, can break down histidine in the fish into histamine, which causes an allergic asthma-like presentation. Patients with history of asthma have greater risk of mortality. Shellfish allergy can cause allergic or asthma-like presentations, often literally after eating shellfish like clams or mussels. Don't confuse with scombroid. Students get trigger happy when they learn weird conditions. If USMLE gives shellfish, the answer is shellfish allergy, not scombroid. The latter is from meaty fish and not an allergy. High-yield congenital lung diseases. Starting off with cystic fibrosis. Cystic fibrosis, or CF, is an autosomal recessive on chromosome 7. Mutation is in the CFTR gene, which encodes for the chloride channel. Most common mutation is the delta F508, which is a deletion of the phenylalanine. The USMLE wants abnormal protein structure or abnormal protein folding, a common mechanistic answer for CF. In the disease, the CFTR chloride channel, normally is located at the cell surface, is instead sequestered at the rough ER, at the RER. This is a high-yield point. It says in the disease, the CFTR chloride channel is usually located at the cell surface. This is sequestered at the rough ER, rough endoplasmic reticulum, I think. This is why high-yield point, where they want you to know that the patient with the disease do not have the chloride channel on the cell membrane. The disease results in impaired ability to secrete chloride into the alveolar and pancreatic secretions. This causes a greater negative charge within the cells. Sodium then moves through the increase in ENaC into the cell to balance the charge. Water follows the sodium, resulting in dried up alveolar and pancreatic secretions. These are known as inspissated secretions. Inspissated means desiccated, dried up within a lumen. The inspissated alveolar secretions lead to a mucus plugging, airway obstruction, and recurrent pneumonias. The inspissated pancreatic secretions leads to an exocrine pancreatic insufficiency, high-yield phrase, exocrine pancreatic insufficiency, and fat-soluble vitamin malabsorption. It is my observation that vitamin E deficiency is the highest yield vitamin deficiency due to the CF across NBME questions, which will present as a neuropathy in a child who has cystic fibrosis. Meconium ileus high yield refers to the failure to pass stool in the first 24 hours after birth. That is to say, the meconium, which is the first stool, does not pass in the first 24 hours because of the condition. Very key calling card for that, CF. CF can sometimes cause nasal polyps. USMLE doesn't obsess over pathogen causes for CF pneumonia, but classically Pseudomonas is a culprit. Prior to the age of 10, Staph aureus succeeds Pseudomonas as the most likely organism. After the age of 10, Pseudomonas eclipses Staph aureus. The caveat is that if you use your head, though, as they say an 8-year-old with a pneumonia due to gram-negative rods, you know that it's Pseudomonas. Likewise, if they say a 17-year-old with pneumonia due to a gram-positive cocci in clusters, you know that it's Staph aureus. Sweat glands reabsorb chloride rather than secrete it. This is impaired in CF. So we have an increase in chloride in the sweat, that is to say, an increase greater than 60 milliequivalents per liter. The sweat chloride test is more accurate for diagnosis than genotyping due to the allelic heterogeneity of CFTR gene. So that's interesting. So they're basically saying just use the phenotype instead because the actual genotype might be variable. And so it doesn't necessarily tell you about what the actual phenotype might be because of variation between people. The heterogeneity, right, of the CFTR gene, where many different mutations can cause the disease and it can be difficult to detect with routine screening panels. A transepithelial nasal voltage test can also be done where there is an increased nasal potential difference. Male patients can have a congenital bilateral abscess or a vas deferens, CBAVD, leading to absent sperm in a sample. Since this is an AR condition, there is a autosomal recessive, this is what they mean, autosomal recessive. There is a 2/3 chance of phenotypically normal sibling of a CF patient and is a carrier. This applies to any autosomal recessive disorder, but USMLE likes to use CF as the archetypal example. If this 2/3 point sounds confusing, I talk about this stuff in detail in my high yield genetics PDF. If you want to read more about how Punnett squares work, be my guest. Let's say, for example, both of your parents are carriers for CF. There's a 1 out of 4 chance that you will have CF. If one of your parents has CF and the other parent is a carrier, there's a 50% chance you will have CF. If one parent is a carrier or has the disease and the other parent is neither a carrier nor has a disease, they just have no version of it, not 1 or 2 copies, they have 0 copies, then all the kids will be carriers. If let's say, for example, you have CF and your partner, person of the opposite sex for whom you can reproduce with, let's say, has no copies whatsoever. You have 2 copies, they have 0. All of your kids will be carriers. None of them will have the phenotype of cystic fibrosis, but they all have a carrier copy. If you are a carrier of 1 copy and your partner is a carrier of 1 copy, your kids have a 25% chance of getting both copies and therefore getting CF. Half of them won't be carriers, 50% won't be carriers and only have 1 copy, and 25% will have 0 copies. So that's how it works as a Punnett square. I'm not sure where they're getting the 2/3 chance of phenotypically normal, is what they're referring to. I would assume they mean 3/4 if both parents are carriers, but I don't know. Back to the CF stuff. CF medications are not high yield for STEP, but you could be aware that the CAFTOR agents, i.e. ivacaftor, lumacaftor, facilitate with proper CFTR channel localization to the cell membrane plus structural folding. Dornase alpha, correct, not alpha, with an F, with not a PH, is a nucleotidase that softens mucus. Guaifenesin is also a mucus softening agent. Let's talk about primary ciliary dyskinesia, also called Carter-Jenner syndrome. Answer on the USMLE for a question that sounds like CF, but patient has a situs inversus or dextrocardia, that is to say, patient with a recurrent pneumonias in organs or just heart on opposite side of the body. Abnormality of the cilia function due to the defective D9 arm. This is a high yield point where sometimes the patient will just be D9. A cilium on a cross section has a 9x2 microtubule configuration. D9 is a molecule that is necessary for cilia function. Patient will sperm and sample. Well, I think they mean patient will have a sperm sample, but the mortality of the sperm sample will be decreased. This is in contrast to CF, where sperm has been absent due to CBAVD. Women can get ectopic pregnancy due to the abnormal fallopian tube cilia. This diagnosis sounds straightforward enough, but I've seen plenty of students miss these questions. For the situs inversus, they will describe this as a cardiac sounds loudest on the right, or there will be a large mass palpable beneath the left costal margin, liver on the opposite side. Next, we have the primary pulmonary hypertension, or PPH. So, answer on the USMLE for women 20s to 30s, non-smoker who has increased pulmonary vascularity markings and either has a loud P2 or a tricuspid regurgitation, as I talked about in cardio section. These are high-yield findings for pulmonary hypertension. Primary means that pulmonary hypertension inherently starts with the lungs and is not due to a secondary, that is to say, external cause such as smoking, CF, systemic sclerosis, etc., due to mutations in the BMPR2 gene. Do not confuse this with cor pulmonale. Recall that the latter is right heart failure findings or right ventricular structural finding changes due to the pulmonary cause. If the question gives evidence of the right ventricular hypertrophy, that is to say, right bundle branch block, right axis deviation on EKG, boot-shaped heart on chest x-ray, or has overt right heart failure findings, like, for example, JVD or peripheral edema, then we can say that the patient now has cor pulmonale due to the primary pulmonary hypertension. A loud P2 and tricuspid regurgitation, however, are high-yield findings for pulmonary hypertension that does not necessarily mean cor pulmonale. One of the highest yield points is the endothelin 1, with it is increased on these patients. This is a vasoconstrictor that is increased in pulmonary hypertension from any cause, but notably USMLE likes it for PPH, the primary pulmonary hypertension. Bosentan blocks endothelin 1 receptors and is high-yield treatment for PPH. I'm going to take a brief break again. Well, I mean brief break, I mean like a few minutes. So just skip ahead if you're watching the recording. Okay, let's continue. Yeah, by the way, now I'm back. So again, we're trying to get to, we're on 40. We were on 40. We started off, we'll get to we're on 56 right now. We were trying to get through halfway through the chapter, which to me, it's 38 pages. I'm going to get through 20 pages maybe, so maybe I'll wrap up at 60-ish. And I call it for this video. So let's continue. High-yield autoimmune-related pulmonary conditions. Systemic sclerosis, aka scleroderma. Idiopathic autoimmune disease characterized by multi-organ system fibrosis and hardening of tissues, that is to say, sclerosis, divided into limited and diffuse subtypes. Limited scleroderma equals CREST syndrome, calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasias. USMLE can describe Raynaud as color change of the fingers with cold weather. They describe sclerodactyly as tightening of the skin on the fingers, esophageal dysmotility present as GERD. I haven't seen NBME care about calcinosis, which is about abnormal calcium deposition in tissues. Diffuse scleroderma, CREST syndrome, plus renal involvement, presenting as an ultra-high yield blood pressure, that is to say, for example, 220/120, due to the renal involvement caused by a surge in the RAS. If patient doesn't, which is a renin-angiotensin-aldosterone system, if the patient doesn't have a high BP, it's not diffuse type on USMLE. Apart from just being able to diagnose these conditions, the highest yield point on the USMLE is that both types cause pulmonary fibrosis, leading to pulmonary hypertension. Pericardial fibrosis can also occur. An offline NBME wants a decrease in the lower esophageal sphincter tone and a decrease in the esophageal peristalsis as an answer. USMLE wants dress warmly in cold weather as an answer for how to decrease recurrence of Raynaud. Dihydropyridine calcium channel blockers can also be used, like nifedipine, which increases the arteriolar plus capillary diameter. USMLE wants to know which of the drugs for you to avoid in patients with Raynaud. The answer is going to be alpha-1 agonists like phenylephrine, oxymetazoline, since these constrict arterioles and capillaries. What about sarcoidosis? Sarcoidosis, idiopathic autoimmune disorder that is one of the highest yield conditions on USMLE. You must know this condition extremely well. Characterized by non-caseating granulomas within the lung tissue, these consist of activated macrophages called epithelioid macrophages, aka histiocytes. These histiocytes in the lung secrete 1-alpha hydroxylase, normally reproduced in the PCT, proximal convoluted tubule, of the kidney in response to PTH, which will convert the inactive 25-OH-D3 into active 125-OH-2-D3, so basically an active form of the vitamin D3, i.e. causing high vitamin D, aka hypervitaminosis D, which then goes on to small bowel and increase the absorption of calcium, causing hypercalcemia. Even though 125-OH-2-D3 also increases small bowel absorption of phosphate along with calcium, it is to my observation that the phosphate can be normal in sarcoidosis and NBME questions. So do not confuse if you see phosphate in the normal range and only see the hypercalcemia. So they're saying that you can, even in NBME questions, you might have the phosphate be normal, but it still means it can still be sarcoidosis as far as we're concerned about answers for the question. PTH is suppressed in sarcoidosis due to the high calcium exceedingly high yield. In other words, on USMLE, you will select the elevated 125-hydroxy 2D3 and the decrease in the PTH. Archetypal presentation is African American woman, 20s to 30s, with 6+ months of dry cough and red shins, erythema nodosum. Other findings like low-grade fever with flares can occasionally be seen. Bihilar lymphadenopathy seen on chest X-ray or CT. They can also describe this as chest X-ray or CT, shows hilar nodularity. And so you can see that right there. There is a 2CK question which gives early 30s African American woman with dry cough, plus they say the chest X-ray shows no abnormalities. The answer is going to be activation of mast cells. That is to say, asthma is the answer. Wrong answer is non-caseating granulomatous inflammation. So your high yield point is this. If the vignette sounds like it could be sarcoidosis, but they have a chest x-ray which is normal or shows mild hyperinflation, also buzzy for asthma, choose asthma over sarcoidosis. A 2CK-IM CMS form gives sarcoidosis vignette where they mention bihilar lymphadenopathy on a CT scan, plus high hepatic AST and ALP, plus weight loss. They don't mention the hypercalcemia. Unusual combination of findings, but the answer is inferable based on the CT. Lupus pernio is an enlarged nose due to the sarcoidosis, not lupus despite the name. USMLE wants steroids, that is to say oral prednisone, as the treatment. Rheumatoid lung. Rheumatoid arthritis can cause a restrictive lung disease known as rheumatoid lung. In addition, methotrexate, the first-line DMARD for rheumatoid arthritis, can cause pulmonary fibrosis. So patients with advanced rheumatoid arthritis can have pulmonary fibrosis from a combo of the two, either the rheumatoid arthritis, or either the rheumatoid lung itself, or the methotrexate that you're using to treat the rheumatoid arthritis. Next section is going to be high-yield pulmonary embolic conditions, starting off with PE, or pulmonary embolism. DVT that has embolized up the venous circulation to the pulmonary arteries presents as an acute onset shortness of breath and tachycardia in patient with one of the following risk factors post-surgery, including C-section, sedentation, e.g. due to a trauma such as a hip injury or oral contraceptive use, and thrombotic disorders like i.e. FVL, prothrombin mutation, MTHFR. S1Q3T3 is most specific finding on EKG for the PE that is non-existent on USMLE and will get skew questions wrong. What you want to remember is that sinus tachycardia, that is to say normal EKG but heart rate simply high, is the most common EKG finding for pulmonary embolisms, is sinus tachycardia. First step in management 2CK is heparin. After heparin, do a spiral CT of the chest to diagnose. If the patient is already on warfarin and gets a PE, the first answer they want is CT to diagnose, followed by an IVC filter. Do not choose IVC filter prior to confirming the PE with a CT. One 2CK MBME question has a TPA, tissue plasminogen activase. Is that TPA? Is that how you say it? Tissue TPA, tissue plasminogen activator. So, where were we? So on 2CK NBME question has a tissue plasminogen activator TPA as the answer for PE in patients who has obstructive shock, that is to say low BP due to the pulmonary embolism. A VQ scan is done instead of CT first line in pregnancy. On 2CK questions, give VQ that is performed on shows a multiple subsegmental perfusion defects. Answer should be equal to the recurrent pulmonary emboli. Most common cause of death from PE is ventricular fibrillation, VFib. Acute right heart strain from a saddle embolus precipitates the VFib. Continuing with pulmonary embolism here, the acid-base arrows for USMLE wants for PE are decreased CO2, increased pH, no change in bicarb. In other words, we have an acute respiratory alkalosis from a high respiratory rate. Bicarb is unchanged because the kidneys requires minimum 12 hours to accomplish this. These arrows are the same as the acute asthma attack. On 2CK, questions give lab values of PE of decreased carbon dioxide and a decrease in the pH. This means that the patient has lactic acidosis, hence the decrease in bicarb due to the ischemia from poor perfusion. It's high yield for USMLE that you know any cause of shock, whether that's be septic, hypovolemic, cardiogenic, or even obstructive from PE, can cause lactic acidosis and low bicarb. Don't be confused by this. The physical pulmonary embolism is textbook example of dead space, as discussed earlier. Amniotic fluid embolism. The answer on the USMLE, if they say that 30 seconds to 2 minutes after delivery of the placenta, the patient gets shortness of breath and tachycardia leading to sounds like PE, but the answer is amniotic fluid embolism due to the lungs. In contrast, if they say a woman has a C-section 2 days ago, plus now gets up in the hospital to use a bathroom, plus now has acute onset shortness of breath and tachycardia, leading to an answer is PE, not amniotic fluid embolism, can cause disseminated intravascular coagulation, DIC. It's one of the weird causes of for USMLE. They say the patient has bleeding from the IV sites / catheter lines following delivery of the placenta. Fat embolism. The patient on USMLE, if they say long bone fracture, that is to say usually the femur, in patient who now develops shortness of breath plus petechiae on the shoulder / chest, the patient will also have thrombocytopenia, but only about half of vignettes mention this. The petechiae on the shoulder / chest are not due to the decrease in platelets, since the conditions like ITP, for instance, don't present with this finding. Literature suggests it might be related to the microvascular plugging by fat in the dermis. Question can mention pulmonary biopsy stain with the oil red O or Sudan black stains for fat. Air embolism. The answer in USMLE, if they say the patient has a sudden death following insertion of a central venous line, would be the air goes to the lungs plus kills patient. Cholesterol embolism will present as two ways on USMLE. One, violaceous lesions on the feet in someone who has just had an AAA repair, which is, again, that's the abdominal aortic aneurysm repair. Cholesterol plaque launches off to the feet, plus they show the image that looks like this one below. The secondary way, the 2CK-MBME10 has cholesterol emboli question, which they don't show an image, but it describes the violaceous foot lesions in someone with mere history of AAA rather than undergoing repair. They say Maltese crosses are seen, obscure, but apparently refers to the birefringence of cholesterol esters that can be visualized under polarized light. High yield trauma and pleural space conditions. High yield trauma and pleural space conditions. Pulmonary contusion. Difficult diagnosis in 2CK forms. Diagnosis of exclusion, meaning that all of the 2CK questions require eliminating the other answer choices to get there. Well, that's not fun. The question will say the patient was in an accident, plus now has some form of difficulty breathing and patchy infiltrates in one or more areas of the lung. They may or may not mention friction rubs just above the area of infiltrates. Sounds vague, as I said, but that's what USMLE will say. Textbook descriptors such as white out of the lung are nonsense. I don't think I've ever seen this on an NBME material. Contused or bruised lung is known to be fluid sensitive, where the question can say the patient was given an IV saline and now has worsening of O2 saturation. This is classic, but I've also seen in myocardial contusion questions, making the diagnosis difficult, as I've said. But you'll be able to eliminate the myocardial contusion if they don't mention severe bruising or pain over the sternum or post-MVA arrhythmias. That is to say, for example, premature atrial contractions. Flailed chest. The answer on the 2CK forms if they say a patient has paradoxical breathing, that is to say the chest wall moves outward with expiration and inward with inspiration. Ruptured bronchus. The answer on 2CK forms if they say there's a persistent air leak despite placement of a chest tube, this will be in a trauma patient. Diaphragmatic rupture. The answer on the 2CK forms for an MVA followed by a chest x-ray. Can I just get a definition for something quickly? MVA. What are we talking about MVA in this context? MVA chest x-ray. It says MVA refers to a motor vehicle accident. I think we were talking about that in our last chapter. I don't know in the first or second video for that, but MVA in this case means motor vehicle accident. So let's go back to flailed chest. The answer in the CK2 form is if they say a patient has a paradoxical breathing, that is to say the chest wall moves outward and with expiration and inward with inspiration. Ruptured bronchus. The answer in the 2CK forms if they say there's a persistent air leak despite placement of a chest tube, this will be in a trauma patient. Diaphragmatic rupture. The answer in the 2CK forms for a motor vehicle accident followed by a chest x-ray showing obscured left hemidiaphragm and the nasogastric tube present in the lower left side of the chest. Don't confuse with ruptured bronchus above or with the esophageal rupture, which will tell you water-soluble contrast swallow is visualized in the mediastinum. Pneumothorax. This is we'll go into it. Let's talk about it. Okay, pneumothorax, air in the pleural space. The term almost always refers to a spontaneous pneumothorax, which will be acute onset of sharp chest pain in a tall, lanky patient in teens or early 20s due to a ruptured subapical bleb. Pneumothorax plus low BP equals tension pneumothorax. Mechanism for tension pneumothorax is compression of vena cavas leading to a decrease in the venous return, which can lead to a JVD. Simple spontaneous pneumothoraxes cause ipsilateral tracheal shift. Tension pneumothoraxes cause a contralateral tracheal shift, and tension pneumothorax need not be not due to overt trauma. It will literally just be pneumothorax plus low BP 9 out of 10 times on USMLE. I've seen only one question on a 2CK form where the BP is lower and of normal, but the patient is tachy around 120 BPM, implying barely holding a BP in normal range. So normally when they're talking about tension pneumothorax, they usually mean a person who's low BP. And in tension pneumothorax, again, it causes a contralateral tracheal shift. So let's say, for example, I have a lung collapse on my left side. The lung will have from a tension pneumothorax, let's say the lung collapse on the left side from tension pneumothorax, the actual midline structures will go to the right. They'll go away from it. Contralateral shift of the midline structure of the trachea. But for simple spontaneous pneumothorax, it causes a shift towards it. So let's say, for example, I have a spontaneous pneumothorax, simple pneumothorax, the trachea shifts towards it. But if I have a tension pneumothorax, again, related to low BP, it shifts away from it. Let's continue. Patients will have hyperresonance to percussion, decrease in breath sounds, and decrease in tactile fremitus. Breath sounds are decreased because of the air in the pleural space masks the sounds of underlying airflow in the alveoli. Tactile fremitus is decreased because of the vibration of the air in the alveoli is masked by the overlying air. Treatment for pneumothorax is needle decompression followed by chest tube. That phrase is high yield. Let me again. Treatment for pneumothorax is needle compression followed by chest tube. That phrase is high yield. 1-2CK question just has tube thoracostomy as the answer without needle decompression being listed. So if they don't list the needle, don't be confused and just choose the chest tube. Thoracostomy means making a hole in the thorax. Okay. But again, treatment with pneumothorax is needle decompression followed by chest tube. That's what the normal answer would be. If they don't have that, maybe you have to choose tube thoracostomy. Let's continue. Pleurodesis. I've never seen this as a correct answer in NBME material, but can be listed as a distractor, leading to means putting talc into pleural space to obliterate it in patients who have recurrent pneumothoraces. I've heard about that before. We had this as part of one of our cases in class, or at our school, I should say. Should be noted that very small pneumothoraces, a stable patient with minimal symptoms can be observed. There is one question on a 2CK NBME form where the answer is observe, but the vignette goes out of its way to emphasize how unremarkable the patient's presentation is. So when it's saying, if it's so unremarkable and so minimal and so asymptomatic, you could observe. But normally, you want to do the needle decompression followed by chest tube. There is a 2CK question where the pneumothorax is caused by a barotrauma from ascending too quickly from underwater. This is different from Caisson's disease, the bends, where nitrogen bubbles form in the blood. Pulmonary barotrauma from quick ascent resulting in pneumothorax can occur if some of the alveoli expand too quickly. I want to see how long this section overall lands. So I might just finish them on 61 rather than 60. Because I just want to wrap up the section area, you know. So pleural effusion. Fluid in the pleural space often refers to hydrothorax, which means transudate or exudate of plasma-like fluid. USMLE wants dullness to percussion, decrease in breath sounds, and a decrease in tactile fremitus. Similar to pneumothorax, the latter two are decreased because of the fluid in the overlying pleural space masks the air movement in the alveoli. Many causes of pleural effusion on USMLE. I've observed left heart failure as a notable cause, that is to say the patient will have pulmonary edema, plus or minus pleural effusion. MBME can also give you pleural effusion with pneumonias, tuberculosis, and aortic dissection. Meigs syndrome, Meigs syndrome, MEIGS syndrome, triad of ovarian fibroma, ascites, right-sided pleural effusion. USMLE wants you to know that transudative versus exudative pleural effusions lead to transudative or more like water, or more water-like with fewer solutes. The exudates contain more solutes. So exudative contains more solutes, transudative contains more water-like presentation. As per Light's criteria, high yield for both steps 1 and 2 CK, an exudate will have pleural fluid protein serum protein ratios greater than 0.5, pleural fluid LDH serum LDH ratio is greater than 0.6, pleural fluid LDH greater than 2/3 upper limit of normal of serum LDH. In other words, transudate contains less protein than LDH as the two main distinctions. Transudates contain fewer white blood cells than exudates, but I routinely see 500 white blood cells over microliters in the transudate question on MBME. Highest yield cause of transudate on USMLE is left heart failure, as discussed in the cardio PDF. ARDS, pulmonary emboli, and infections can cause exudative pleural effusions due to the inflammation. Progression to empyema, high yield, see below. Or empyema, I should say. And we're talking all here about pleural effusion. So what about empyema? Empyema, two ways empyema presents on MBME. 4 out of 5 questions it will present as a sequence of pneumonia, parapneumonic effusions, i.e. exudative pleural effusions that occur due to the pneumonia, and then empyema. In other words, if a patient has a pneumonia that then leads to an exudative pleural effusion, we simply call it a parapneumonic effusion. This effusion can become progressively worse and purulent to the point that the pH of the pleural fluid falls to below 7.1-ish. We call that now empyema, which is frank pus in the pleural space. Low pH of the pleural fluid is to be less than 7.1. Is very high yield on 2CK forms. I've seen questions where they say 7.12, 7.11, and 6.99, and they want emphysema. Well, that's really splitting hairs at that point, but okay. But low pH of the pleural fluid to less than 7.1. 1 out of 5 questions will not mention anything about history of pneumonia. They will give patients who has a persistent fever plus recurrent pleural effusions and someone who has cirrhosis, that is to say, decreasing oncotic pressure, leading to transudative pleural effusions, then the answer is just empyema. MBME wants tube thoracostomy to drain the purulence. Chylothorax. Chyle, lymph fluid, is the pleural space. The answer when they tell you a patient has a milky or white cloudy fluid in the pleural space where the pH is significantly above 7.1. For instance, they might give you a 15-line paragraph where they say milky fluid plus tons of lab values, but you notice the pH of the pleural fluid is 7.4. This means that it's chylothorax, and empyema would be wrong. It can be caused by iatrogenically by insertion of a central line via the left internal jugular vein, or by cancers, for example, lymphoma. Hemothorax, blood in the pleural space. Apart from massive trauma, the way it shows up on USMLE is a malignant pleural effusion. They'll give you a massive paragraph with tons of info and tell you the patient has a history of breast or lung cancer, plus has dullness to percussion, leading to an answer that equals malignant pleural effusion. Patient can have hypotension and muffled heart sounds similar to cardiac tamponade, but rather than JVD to complete Bactria, they can have a flattened neck veins due to the loss of blood from the circulation. So again, hemothorax might be indicative of something like a malignant pleural effusion. History of breast cancer or lung cancer, dullness percussion. Answer, malignant pleural effusion. Okay? Blood in the pleural space. And we would go on to high-yield alveolar fluid conditions, but we're on page 62, and our chapter finishes up, I think, on, let me see, on page where is it? Page 77. So, basically I want to wrap up that second half of or second section, second part, you could say, of this chapter of the PDF tomorrow, presumably, hopefully tomorrow. And I just want to wrap up the video here. So if you like this video, hopefully it was of use to you if you're watching it. If you like the video, you can like and subscribe and do all that kind of stuff. Leave a positive comment, perhaps. I don't know. But regardless, have a great rest of your day, and